inclusive with an unstable ankle fracture. We're going to try to recruit we are going to recruit 890 patients, 445 in each arm between now, you guys will be the first to go live, and September 2021, with a minimum of 26 recruiting sites, and we're hoping for about 2 patients per month per recruiting site. And they're looking at 2 different studies in this one here. Initially the first 12 months, and then the longer term over 5 years as well. So both will be published. The primary question that we're asking is, what is ankle function at 4 months after treatment in people with unstable ankle fractures treated with closed contact cast not worse than those treated with surgical intervention? So we're not looking is one better than the other, we're just seeing is closed contact casting not worse than the surgical interventions. And the main outcome measure is the OMAS, the ankle score. The things that we'll be collecting, that the research nurses are going to want to be collecting, is the OMAS, an A4, which is another ankle fracture outcome rehab measurement, the global rating of change question, and that's going to be looking at ankle function, quality of life, so EQ5D, plus the work productivity and activity impairment score, any risk of complications, so that'll be by self-reported questionnaires, as well as we're going through the medical notes, looking for infections, DVTs, PEs, or unplanned return to theatres. And also they're going to be looking at the radiographs to see if was there any fracture displacement, non-unions, malunions. And then from a resource comparative cost effectiveness, the medical notes, as well as the bespoke resource use questionnaire that goes to the patient themselves. So, getting to the nitty-gritty of it, the inclusion criteria. So as I said, age 18 to 60 inclusive with an unstable ankle fracture. Now, we're not going to tell you what's unstable, that's up to the treating clinician to decide. But if you've got any patient in your clinic that comes up with those, please contact the research nurses because they need to be screened, even if you deem the next, stability, as I said, is, that one thing we will be measuring is there a presence of a posterior malleolus fracture? So we're not saying that's what is deemed to be unstable, but that's what we're going to collect data on as well. So you guys deem what's unstable and what's stable, we're just going to collect what's posterior malleolus fracture involved. And you believe that the fracture can be managed with internal fixation. And so all those 3 need to be ticked for the patient to be eligible. But if you feel that internal fixation can't be performed, then the patient should not be included into the trial, but it should still be screened by the research team. So if you think the skin's just not viable for internal fixation, then they're not eligible for the trial, but they still need to be screened. Okay? So if it meets all 3, then they're eligible for the FAME trial. Exclusion criteria, it's pretty open. So any fracture that's open, any that's complicated by a tumour, injuries of isolated medial malleolus, so isolated fracture, an index injury that occurred more than 14 days, so it has to be within 14 days of the injury happening itself. The patient is unable to adhere to the trial procedures, or if they've previously randomised in FAME trials, so they've already broken one and they happen to unfortunately break the other, they can't be put into the trial twice. Okay? So from a randomisation point of view, prior to randomisation, you've got to ensure that obviously everything is eligible, and as I said, that internal fixation is a viable option. You can randomise any time prior to reducing it in theatre. Okay, so you have to re-prioritise to one or the other before you try to reduce them. As obviously as close to the time as theatre as possible to avoid any potential protocol deviations. One thing they're asking is please don't let your patient know which way they've been randomised into. Okay, so they've obviously consented that they're happy for either, but they're trying to say don't tell them prior to, because things may change in theatre and they might come out with something different than what you've told they're going to come out with. So you have to make sure that you consent them for both procedures, and also remember that you still need to undergo the normal theatre consent, but they'll also have a research consent as well to be part of the trial. So the protocol, the method of for internal fixation, the method of internal fixation is completely up to the treating surgeon. The weight bearing and follow-up is completely up to the treating surgeon as well. If a patient is randomised to internal fixation, but for any reason they're not able to perform it, then that will be considered as a protocol deviation. And that's why I was saying before, make sure that you're happy that they can definitely have internal fixation before you randomise them into the trial. And please don't, if you get in there and decide actually this isn't for internal fixation, I can't do it on this skin, don't don't cross over to a close contact cast. You can do anything else, X fixes, whatever you like, but please don't go back to a close contact cast unless they've been randomised to a close contact cast in the trial. So for the close contact cast, the initial application must be performed in theatre under anaesthetic, and that was produced by the people who created the trial themselves, and also the PPI, so the patient involvement, made that a clear stipulation that it needed to be under anaesthetic, not in a classroom for the initial one. And the reason for that is it allows proper reduction of the fracture under an image intensifier. It also allows you to apply the necessary force to mould the close contact cast. But this is the next one. So it allows conversion to internal fixation or any other management if you feel that you're unable to reduce it satisfactorily, or if you're unable to hold it in a close contact cast when you look under II. And that is not, that's not a protocol deviation. So if you get in there, they've been randomised to a close contact cast, you try to reduce them, and there's just no way close you can reduce them, you can then proceed to do whatever you feel is necessary. And then it'll all just be, all the information will be collected. Or vice versa, if you manage to correct it, but then you put all the close cast on, and then it doesn't hold, again, you can then proceed to anything you feel is necessary, and that's not a protocol deviation. That's an anticipated outcome for some patients. The close contact cast must be performed by a clinician who's undergone this training. So it can't just be, so if anyone who isn't here, they can't actually apply for close contact cast, and that's part of the trial as well. And also, you'll do this anyway, please remember to save your radiographs showing the reduced position in the close contact cast, because all the radiographs will be collected. Once they've had, if they've been randomised to close contact cast, they remain non-weight bearing for the duration of the close contact cast, but then any subsequent weight bearing once the cast is off is up to the treating clinician. VTE prophylaxis is up to your local hospital policy. And follow-up is at the discretion of the treating surgeon as well. And just to give you, in Oxford, what our normal practice is we follow them up at 1 and 2 weeks for the radiographs to make sure that the fracture reduction is the maintenance of reduction achieved in theatre, and also to check if there's any loosening of the cast as well. And if there's any concerns at that stage, we follow them up 1 week later and do the same thing. And we'll talk about that in a minute. So it is anticipated that some participants will require repeat application of close contact cast as it becomes loose, due to the reduction of swelling and also the onset of muscle wasting. Now, to maintain the fracture reduction, the cast mustn't have any space in it, and we'll talk about whole close contact cast in a minute. Reapplication of the cast should happen at the earliest signs of loosening. It's not a protocol deviation, so it's expected. And this can be performed outside the operating theatre, say in the classroom, but it must again be performed by someone who's been to this teaching session. And then repeat radiographs must be performed to confirm the reduction has been maintained. Okay, so that's the difference between the initial one and the subsequent application if you find the cast is loose. From a rehabilitation point of view, standard rehabilitation is going to be used for both treatment options. It's going to be delivered when the clinical decision is to remove the weight-bearing restrictions and the movement restrictions. And then there's a rehab booklet that goes, that'll be given to the patient and be discussed with them. And this includes information about pain, their swelling, stiffness and function. And any healthcare professional who delivers the rehab, we'll be collecting information about who delivers it, their band, where it was delivered, was it in clinic or elsewhere, as well as how long did it take you. And that's all we're measuring from a rehab, and that's the minimum rehab that the patient must have. Any further formal rehab is left to you guys to decide, and it's not standardised, but data will be collected from the patients. Okay, so we will collect what rehab they have had, but we're not telling you what they must have and telling the physios what they must do. So the minimum that must be given is the rehab booklet that comes with all the advice in it. So teaching about the close contact cast. So it's another version of a total contact cast, and the whole thing is it's got a lot less padding than a normal cast, so therefore there's a lot less movement that's allowed to be in the cast. So it's similar to the application of a normal cast, but with minimal padding that's designed to hold the fracture. So the difference between a total contact and a close contact is you actually apply some moulding to keep the fracture in place. Now, there's padding underneath the cast for moulded points as well as high-risk areas. So any bony prominence or areas that the patient will rest their leg down onto their Achilles or their heel. So we put some padding, and we'll have a look at that. Close contact cast should be applied when the acute swelling subsided, and when no significant swelling is expected, which is about similar time to when you would consider internal fixation. You should also ensure you can achieve satisfactory reduction using the II prior to setting up the close contact cast. So if they've been randomised, make sure you can reduce them before you get all the stuff out and ready for it. And then practice holding the position of the leg for the cast prior to the cast. So therefore you know what you're going to have to do once the cast, because don't forget, once you put the cast on, it's going to start setting. You want to know exactly what you're going to be able to do. And Bob Hanley in the video talks about that in just a bit. There are specific moulding points and corresponding site pressure pads aimed to prevent the fracture displacement and also minimise the risk of skin damage. The location of these moulding points are specific to the participant's fracture, so it's not always the same for each patient. So therefore, the application required to hold the fracture is the decision of the treating surgeon. So you look at the X-ray, you decide where you need to push it, and carry on from there. And Bob talks about that again in a little bit. So we won't fly through all these, but in essence, this is the material you'll need for a close contact cast. It'll be a stocking net, a fleecy foam that cut out to protect all those bony points we were talking about. So it'll be written tibial spine, interarticular crest, the metatarsal heads, the fibular head, the heel and the Achilles, the lateral malleolus and the moulding point you'll use on that side, and the medial malleolus and the moulding point on that side. And then also, what you've got to remember is there's very little padding underneath this cast, so it's really important you also put a strip of fleecy transverse where you think you're going to cut the cast off, because you want to protect the patient's skin, whoever does cut it off in the end. So how to do it? So following your satisfactory reduction of the fracture, you then apply the stocking net. You'll hold the ankle, and this is important, you must hold the ankle in plantar grade at that stage right from the beginning, not once you've applied it and then you push the cast, because that will then cause pressure areas on the inside and it'll start splitting the cast as well. But also, if you do it after you've applied the stocking net and all the pads, then when you move it, it'll move where you put your pressure pads. Okay, so it's important to hold it in the correct position right from the beginning and then do everything after that. So you're going to apply your foam, as we spoke about, into the pressure points and moulding points. Apply the thin strip we were talking about in terms of the cutting zones, so to make sure that you don't cut or burn the patient. And also, you might not be the people who are going to take this cast off, so make sure you mark on the cast where you put the cutting zone so that people know where to cut. And we'll talk about that when we go and practice later on. When you apply the plaster of Paris, you put a small amount of tension on, and that helps it to snug to the patient's leg, but don't put too much tension because this can cause ridges on the inside of the cast. And then as you go, like a normal cast, you want to smooth the cast, and this will help disperse all the air bubbles in there and ensure that the cast snugs close to the patient's leg, because don't forget, this is what's holding that fracture in the correct position. Once the plaster of Paris has been applied, then you use your predetermined moulding points to hold the reduced until the cast goes off. And then to give it some stability, later you don't have to do this in theatre, but later down the line you'd also need to make sure before they go home you give a fiberglass cast over the top of it to give it some rigidity. So you don't need to use a lot of plaster of Paris. That's what the fiberglass is there to do. And that was just reminding you to, so this is a big one as well. When you apply the cast, you have to write close contact cast, TCC, minimal padding or something on the cast, so that people know when they're cutting it off, there's not a huge amount of padding underneath. And that was according to the British Orthopaedic Association standards that they're taught in the casting course. So, I shall be quiet and let Bob do some talking. Now, this was created for the AIM trial.
Introduced to you by Keith. My job now is to go through the practicalities of applying close contact cast. As you can see, we've got a willing volunteer, and I've got the basic requirements for positioning the cast.
Can everyone hear it?
Run through the technique a few times. And the objective is to try and show each of the stages and demonstrate why I'm doing them. This cast is being put on for a specific purpose. That's to hold a fracture in a reduced position. Therefore, at the beginning, it's appropriate to check the X-ray to see what you're actually trying to achieve. So looking at the initial films and then the films as they were taken in the emergency room after an initial reduction will be important. The close contact cast is being put on for a purpose, So before beginning, check the x-ray to clear in your mind where you're going to need to apply pressure both to reduce and to hold this fracture. So in this labour C, it can be seen that pressures going to need to be applied both laterally and then more proximally on the medial side. That can be seen on the AP. On the lateral view, it can be seen that as long as the foot is brought up into a plantar position, it should be satisfactory. This shows a provisional reduction achieved in the emergency department, and it shows a position which is satisfactory to protect the medial soft tissues, but is not adequate for the fracture to be left until the union. The lateral view shows the position is satisfactory. On the basis of those views, I know where I'm going to need to apply my pressure points during the moulding, and therefore where I'm going to need to apply the soft tissue padding underneath the cast. Having applied the close contact cast and moulded it, the check x-ray shows some lucency under the cast, and that's the area where the padding resides, both medially and laterally. It's a little bit more distal on the lateral side than the medial side, which is in keeping with the pattern of fracture that we had and where the pressure needed to be applied. And it can be seen where the foam padding had not been placed, that the cast is actually very close to the soft tissue edge. It is indeed, in this case, a close contact cast. And just to cut these out so that they're ready. It's best not to have your rubber gloves on at this point. For putting the moulded cast on, you're going to use plaster of Paris, and so I prefer to wear protective gloves to protect the skin. But the rubber gloves and sticky foam just don't mix particularly well. You have to be prepared to trim these again once you wrap them around the patient's leg, because the length of the tibial crest and the circumference around the metatarsal heads obviously is an estimate at this particular point.
Do we get given these templates?
Yep.
The picture that I have in my mind...
Will we actually get the piece of foam with all the drawings on it? Or
We'll actually send Bob to cut them out for you.
It
comes into the theatre, cuts them out.
Adult to supervise.
With a total contact cast where you're just laying plaster
sticky back plastic?
there, then you rely on that even pressure being generated
When he comes and does your girth,
of the cast, rather like the way it is
cutting these out.
whereas when you're sitting it and it's consequentially very comfortable. As soon as you start to manipulate it though, you're going to give rise to pressure points, and that's why we've chosen to use close contact casting, where you can apply some external forces to manipulate it without having too much risk of pressure areas underneath. So having got the main foam areas produced, the only other thinner piece of foam that is required is this fine foam strip, which is used to lie under the areas where we're subsequently going to cut the cast when it's being removed. So the pre-cut pads are applied to the areas where I know that I'm going to need to mould to achieve and hold a reduction of the fracture. So at and just below the level of the lateral malleolus, and at and just above the level of the medial malleolus, so that I can apply pressure and counter pressure. The rest of the padding is placed in areas where I know that there is going to be either a bony prominence, or the patient is going to rest their leg and the weight is naturally going to give pressure. So over the heel, and up over the Achilles tendon, to protect the common peroneal nerve at the level of the fibular head. Around the metatarsal heads. Unless you're lucky, this one needs to be cut quite often to stop it overlapping. Unlucky, that doesn't need to be done. And then along the tibial crest. And you don't want it going over the dorsum of the foot into the crease of the ankle there, because it provides a pressure point there. So just avoid that and cut that to And then these thin strips of felt we've been using to make removal of the cast safer and more straightforward. So these will be applied along the lines that you want to put the plaster to. So down the lateral side of the tibia, so over the anterior compartment, cut that to length, it doesn't need to overlap at the bottom. And then a shorter piece over the lateral side of the foot, so that the plaster saw can be used in that area as well. I always end up getting that piece far too long. I don't know what size feet I anticipate people are going to have. Trying to get rid of ruffles now, make sure I'm in position. I often check the X-ray at this point just to make sure I'm pushing the right direction. I'm happy that I can achieve the reduction that I want. On the image intensify, the position is satisfactory, and now we're ready to apply cast and mould. Having put the padding in place, the final layer is the orthopaedic bandage, and this you put on really quite firmly as a single layer, so I'm not aiming to overlap it. And this is just to hold everything in position. Keep the ruffles out as much as possible. And just a single layer. Okay, you're happy now. Just hold it, make sure you've got the toe strong so I can wrap the plastic. And now to apply the plaster. You can put, if you're going to wear gloves, this is the time to put them on. If you wear them before, they stick to the sticky back felt. So the plaster is not just laid on like you would with a total contact cast. It is wound on. You're just trying to apply a little bit of tension through the padding that you put on so that it conforms. You want it to conform well without applying uneven pressure. So as you are putting it on over padding, you can afford to just apply a small amount of tension. Check that your foot is implanted right. Just don't relax a little bit, that's good. Because if you have to correct it once the plaster is in position, it's naturally going to crease. If it starts to go crooked, now I'm not putting a great thickness of POP on, it's not necessary, because the purpose of this is not to provide the strength, but to provide the close contact nature of the cast. I can give the strength to this construct by top coat of fiberglass, which can be put on once the position has been achieved and secured. So this is purely to hold position and to make sure that it's well moulded and is close contact. Now final glance at the X-ray. Make sure that you're moulding in the right place. You should be moulding over the pads that you've placed. Just wait for it to set.
So Xavier, this guy, patient wakes up in agony, just because sometimes they do, and you're forced to split the cast. Now what?
using a marker.
Yes, I think if you split it,
on the outside of the plaster
then you're into sort of plaster change scenario, which doesn't have to be done in theatre. So you're into second cast. In terms
Okay.
of protocol.
Okay. And the top coat, you're doing fiberglass in theatre, are you?
We do, because we have it, but there's no requirement for you to have that. We have top, we often top coat in theatre.
Yeah.
So there's no problems with top coat in theatre, or you can top coat on the ward or on the
Yeah.
plaster, however you want to do it. Like.
Okay.
That's not an issue for us. In terms of the trial, that would be just a local site thing.
Right.
I think we talked about that, but just for everyone else, if you have gone through the process, you achieve a good reduction, but at the time you apply the cut and you do your final X-ray and you're not that happy with the reduction, you're meant to take the cast out and
Yeah,
have
so at
another
that stage,
go.
ordinarily we just take the cast down and do it again. If you've got a pre-casting reduction that you're content with and you just didn't achieve that when you did your moulding, then just like if you're doing a distal radius or anything else, we just take the cast off and start again.
Yeah.
At some stage you might
Yeah,
feel
okay,
that my
that's
plaster's just not holding it, and then you can convert to an orif, and that's fine. If you feel that you can't get a cast to hold on to it. So sometimes, because we're pushing the envelope of it, we'll have a relatively big shear fragment at the back with a plantar grade foot, and we're trying to hold it forwards, and it will just keep slipping, and we feel we can't get it to successfully hold, and then we'll convert it to open. Some people may decide that they don't want to tackle those sorts of fractures without a buttress at the back, and that's fine. But reality is, if you put a foot in plantar grade, you can hold almost any shear with the plaster. But different people have different views on that, and that's
Yeah.
totally fine.
Okay.
So that's kind of the end of the video, and so now's the time to ask as many questions about the protocol or we got.
What constitutes your FAME teaching team? Is
Me?
that just this?
Yeah, me. Great.
So, when Seth mentioned the list that happened at the weekend, there's loads of cases that happened at the weekend. Ankle fractures are quite often sisters for a weekend list, done by senior and juniors. Is there any scope for you to make this some kind of online teaching and then have one of our past technicians be able to do the practical bit of it to actually get it? Because I don't think there's probably any of them here, are there? So it just means you just never get this done at the weekend.
So yeah, we're going to put it online as it develops up. The videos, so very shortly, we're just about to get the ethics approval for amendment, which will have the FAME website. And on the FAME website, there'll be a teaching page. It'll have all the videos on it that are relevant to FAME as opposed to all the AIM stuff. And then it'll also have all of this sort of teaching material, some highlights of the protocol, that kind of stuff. When the protocol doesn't specify that the class has to be applied by a surgeon, the surgeon has to make the decision that the reduction is adequate. So you have to still make that fundamental clinical decision. But the application of the cast doesn't have to be done by a surgeon. So we don't do it in Oxford, but when we were in Coventry, we used to have a class text come to all the casting done in theatre. I don't know, I think we've got a couple of class texts. So do you go along and do plastering in theatre?
But no, you don't come into theatre, right?
Okay. But there's no problem with the protocol to have that. Or in the classroom, if you're changing casts over, then that's, we'll make sure that we're happy with the reduction once the cast is on and you get your check X-ray. So that clinical check still happens. But the application of cast can be done by somebody else in the team.
Very self-interested, it's just
No,
upper
sure.
limb. I don't know the weekend list, so just contact cast rather than doing upper limb stuff if I'm the only one that comes to this teaching session. You get a registrar training and then get on with it.
Yeah, absolutely, yeah. I mean, essentially, obviously the close contact element has got links from the total contact casting literature and experience. But essentially, if you read John Charney's book, that is a well applied 3-point fixation cast. There's nothing new in that video. It's just about minimising the amount of casting material that's on, minimising the amount of padding that's on the leg. and then putting the cast in a good position and getting three-point fixation with a moulded technique. And I use the same technique to do distal rhodus fractures to get three-point fixation in kids.
One obvious thing when consenting the patients will be around weight bearing afterwards.
Yeah.
So more and more you hear people talking about weight bearing patients in a boot after their internal fixation. I must say we're probably a little bit behind the curve on that, and not everyone's doing that. But it's in some ways easier to say that the weight bearing will be the same regardless of which treatment you get.
Yeah, so the protocol doesn't absolutely specify. It's got a little bit of greyness around around the close contact cast.
Do you destroy a close contact cast if you walk on it?
No. So the AIM study shows that people walk on no matter what you do to them, they walk between about day 14 and day 21 when their fracture becomes settled enough that they can walk on it and their soft tissue underlay. So when they interviewed all the patients, and in AIM it was really clear. It was explicitly non-weight bearing versus early weight bearing in the ORIF group, and everyone walked on it between about 14 and 21 days, irrespective of their instruction.
Right.
And so here we've said the ORIF arm, you do whatever your local practice is. Not specified at all, made it very explicit that it's surgeon choice. In the close contact arm, we're saying that we would tend to advise a delayed weight bearing, but we don't mandate it. And so if you're a real advocate of early weight bearing or allowing patients to weight bearing is tolerated, then you can push that.
Okay.
We will contact the patients and ask them when they started weight bearing, and we'll report that. But we don't absolutely require you to consent them like that.
Fine.
And as a follow-up, when you are recruiting patients, sometimes in some of the studies, you have a hard time, right? Because some patients might have different ideas of what they want. So any tips on how to present the trial, or what wording do you use? So you say trial, we're trialing on you something. They might go, oh, no, don't trial anything, just do whatever's best for me, and then you lose a lot of patients.
Yeah. So the way that any of us, particularly clinicians, rather than the research team, approach the patients and discuss research, whatever the topic of the research, really sways whether patients are prepared to be involved or not. And so the actual nitty-gritty of getting them to sign the form and tick the right boxes in the right places and put their initials on, that's one part of it. But actually much more profound is how you explain to the patient the idea of doing studies. And I think from a clinician's point of view, that's the biggest thing that you can do to improve the recruitment, and that goes across the board for any research study. So on the FAME website, which will be open in a couple of days' time, is a video of me consenting a patient. It's a bit cheesy because it's sort of set up, but you'll enjoy it. But it tackles some of the big areas that patients find difficult to understand. You know, you're a surgeon, how do you not know how to deal with ankle fractures? What is randomization as a concept? What are the relative risks and benefits of me participating in research as opposed to not participating in research? That sort of thing. And it's mostly just things that have been learned from other trials and trying to incorporate that. You know, so how do you explain randomization without bringing in analogies about betting or taking a chance or computers? Because then people will say to you, well, the computer decides, and obviously the computer's not really deciding. So you start getting difficult conversations that you don't really want to have. So that video tackles most of those things. But I would say there are some real take-homes that participating in research, every patient does better in a trial than not being in a trial. And that's one of the criticisms of trials, that the outcomes are not reflected in real-world practice, because patients are looked after much better if they're in a trial, irrespective of what treatment they get. So being in a trial is good for your care. Being in a hospital that does a lot of research, you get better outcomes. So NIHR has shown that really clearly, that NIHR research active sites like here in Royal London outperform non-research active sites. That's across the board, irrespective of whether you're in trials or not. That we don't know the answers to everything in medicine, and that's just how it is, and that's why we're doing studies, and it shouldn't be surprising, otherwise we'd never advance. If you tackle it like that, people will understand that a bit better. And the randomisation is a process that allows us to design a study where we get a fair comparison. And what we're trying to do is generate two groups of people that look the same, and randomisation is the name that we give to that. Then people understand that. There's a little 1 minute of video that's going to be on, it's an animation, it's in lay language written by a PPI. It's 1 minute long, and if you watch that, it answers pretty much everything you need to know about the FAME study. I actually was trying to get that being that entire consent discussion, but ethics wouldn't quite wear that. And there's nothing about GDPR in it, which upset the university. But those resources will all be online and be available to you to show to patients as well.
So, if you're following someone up then a week down the line and you've got a bit of do you reapply, remould, or do you abandon and you go for?
Yeah, so at 1 week, I find that you can get them back across. So I will remould them at 1 week.
In plastering?
In the plastering at 1 week. A bit of gas in there. It depends, you judge your patient, right? As to whether they're going to find the gas in there more helpful than not.
So that's not a failure of treatment yet?
That's not a failure of treatment, no. I mean, there's, once the patient gets randomised, once the computer says they are going to get that treatment, we're going to follow that patient and collect all the information about them, and they will always be analysed as per that treatment, no matter what they get. Obviously, when it comes to reporting the trial, we'll tell people, this number of people were allocated class, this number of people went on and get an ORF. Just like in the ORF group, this number of people had removal metalwork, this number of people had infections. So you'll be able to sort of map it out. But when you're actually in clinic doing it, then at a week, I think you can get it across. At 2 weeks, it's getting a bit tricky. And I don't attempt it at 3 weeks. If it's not good at 3 weeks, then we're going back to theatre for an open reduction, really. And that's why we watch them quite closely early. It's like distal radius and stuff. You don't want to be trying to tackle a distal radius at 3 weeks.
It's
trying to reapply a
the weekend. It's like, how long's the average for you guys to do ankles on the weekend? Is it 3 quick, or is it still 1 to 2 weeks post injury?
It's going to be 1 to 2.
So then,
it's going to probably the average is about a week.
Can I just ask a question about so you mentioned, I think 14 days is
14 days,
that's to the
I haven't been
same
displaced
or to entry into trial.
Entry to trial, yeah.
I mean, if someone, let's say we're going to a protocol and it's got days, that's the 14 and she's done on Sunday, it's done on Friday, and then it's going to be 16th day, and they should be included, they're randomised on the.
Yeah, as long as they get randomised inside the 14 days.
Okay.
So the only other issue with consent is just what you described. So there's a chance that if we treat you in plaster, it may slip, in which case we're going to give you an operation.
Yeah.
So patients might say, well, I don't want to go to sleep twice. If you're going to put me to sleep once, just go ahead and do the proper operation.
Yes, so that's a really valid concern. Obviously, in the AIM study, about 1 in 5 people had a close contact cast, and then at some point in the next few weeks ended up getting an ORF. A bunch of them had an ORF on table, but some of those people had it at 2 weeks or 3 weeks or 5-6 weeks, when things started to slip. So you got 4 out of 5 people didn't need a subsequent procedure, but 1 out of 5 did. When you run that out to 3 years though, twice the number of people had to have an additional anaesthetic in the ORF group than in the close contact cast group because of complications of ORF, mostly because of removal of metalwork. So actually you're going to have, on average, you have fewer procedures in the close contact cast group than in the ORF group, which is a little bit counterintuitive, but that's why we do the trials.
That's the same operation included removal of metalwork?
Yeah. So if you add up all the operations in the ORF group, all the subsequent operations in the ORF group, there's more in the ORF group than in the close contact cast. About 3 out of 4 were for removal of metalwork. And then the others are people that end up having, the woeful story of a leaky wound, then it burst open, then we went back into private, and there'll be a bunch of people, a small number, who have multiple operations that skew it.
After one frontal decline operation, how late to do general operation?
Normally between about 2 and 3 weeks. because you're watching them quite closely. And once they start to go, if you don't correct that and hold it in the cast, then the talus slips out, starts to go up into the syndesmosis. You know, you get that sort of tilt. The
It's
talus
not
starts
for
to go
another
up.
2 weeks.
No, it's fine. We generally use a fibula now because these are more elderly patients. We're just trying to buttress the fibula back, so we're just doing a little distally based incision, just scoop the fibula now up in. But that, you know, you do whatever you want.
Any other questions at all? Especially as Amy sat there.
How long does it take to do one in theatre?
20 minutes.
You've got 4 lined up for a weekend. You smash it. You'll go
You're out,
really well.
out the door.
You've done it now.
Exactly.
And it's It's quite good for a race driver. We get paid the whole day.
Oh, there you go. So if you're on a normal,
Incentive to do the course for the rest of the
Sort of I'll find some extra cases from the latter session.
if you buy the session rather than buy the case, this is an absolute winner. No, it's definitely faster than an RF. You know, no matter how quick you are, people's RFs still take longer than a cast. Clearly, as you get better at it, and you get better at the moulding, then you get fewer reapplications. Once you put another cast on, pretty much doubles the time. I mean, we'll go through the tips, but you know, thin casts, well moulded, using the II properly, not worrying about getting lots of cast material on, and using the top coats judiciously. Then you end up with a nice, snug, well-fitting cast. And you can feel when the ankle's reduced; it's nice and solid and stable.
Can I just clarify that you're then happy, once the training videos are up, you're happy for people to watch the videos and then to go to our experts to have a practical session and be signed off and
Yeah, and it will be on webcam.
perfect.
Okay.
Yeah.
Guys, this is a little bit cheeky because it's unrelated to this, but there's some ribs that need fixing. I'm around to sort of like be sort of in and out, but I can't fix. I've got a tab here at the same time. Are there any consultants who either already know how to close contact cast or wouldn't be involved in this trial who fancy fixing some ribs?
I'll give the ribs a whirl.
Yeah.
Yeah. I mean,
I
how
think
difficult can it be?
you know, in contract that's the only thing. They're quite hard to knock up at point. Break up kind of.
I can
my
just go
eyes
and tell the
boring to
patient.
back your head.
No.
Oh, Mr. First.
That's not on my record.
No, you don't fancy ribs. Oh, that's a shame. Alright, that's right.
They're just like
Alright.
curvy fibers.
Well, I'm going to agree with you, so...
Yeah. No, don't worry. We'll find something.